Hello, everybody. I'm Molly Howland, an assistant professor and CL psychiatrist at the Cleveland Clinic. I am also the chair of the ACLP's Interprofessional Education Subcommittee, where we're trying to answer the question, how can we all work together? To figure this out, we've talked to a lot of people across professions, and I just wanted to thank everyone who's contributed to both the ongoing dialogue in our subcommittee, but also to this talk. Especially my vice chair, Adrian Mishkin, and the Fellowship Education Subcommittee. We will start with a thought-provoking case. Dr. P is a CL fellow who's at the end of a difficult night shift where she had been scolded by a medicine attending for not admitting a patient to inpatient psych, and she's also experiencing financial stress. She receives a consult for depression. She gets frustrated upon hearing the hospitalist NP's account of how the patient was transiently tearful yesterday and cuts off the NP. People are allowed to have emotions, which you would have learned in medical school, and blocks the console. She vents to her friends who concur that NPs suck. I can't believe they make more money than us despite training less. The NP, who is a recent grad, is upset and wishes he was taught more about how to construct a good consult question. He still has a bad feeling about this patient's emotional state, though. The patient discharges home and attempts suicide. I want everybody watching to think for a moment how this interaction could have been improved from individual to systems level factors. Stay tuned for answers to that question. Here's what we're hoping to accomplish today. We want to recognize the importance of collaboration across professions, become aware of group dynamics principles to decrease enactment, list and leverage the background of non-physician caregivers in CL psychiatry, and apply general and specific strategies for improved collaboration across professions. And we will focus on APPs, a hot topic because of historical APP physician tension. So we will understand professions, we will understand tensions, and then apply some collaboration strategies using 3 different frameworks. But why are we doing all of this? Interprofessional work is intrinsic to CL, but will also happen regardless of where you practice. Even in private practice, you will have to coordinate with the patient's PCP or therapist at times. And being able to work across disciplines is part of ACGME requirements, and the WHO and other acronym organizations have increasingly recognized the urgency of teaching people how to do interprofessional work. I will admit, I'm also inspired to do this because I haven't always been the best at this. I've sent a fair share of bad consults to psychiatry, like in a mostly drowsy, anxious patient with a trach who couldn't really communicate or do therapeutic work. Right, so I'm going to be brief with some of these descriptions of different professions. It's mostly descriptive information so that we can get to some juicier stuff later on, but feel free to peruse the slides more afterward. So we commonly work with nurses in CL. This is either a 2 years associate degree or a 4-year bachelor degree. And then you add on 2 to 3 years of a master's degree for an ARNP. Then a doctorate of nurse practitioning is 3 more years, which is typically a research / leadership degree more than clinical time. There are 4 types of APRNs. There's certified nurse practitioners, which is the majority and what most of us are familiar with, especially on CL. And there are certified registered nurse anesthetists. There are certified nurse midwives, and then clinical nurse specialists. And within the certified NPs, we have several clinical focuses. So for example, acute care NP, which is most of our hospitalist NPs, family medicine NP, psychiatric mental health NP, women's health NP. And these are typically more specialized training programs, less generalized than a PA training program. And these programs typically have pretty variable didactic and clinical experiences. Standardized curricula can be lacking. Clinical experiences may constitute shadowing. It's actually very difficult for NP students to find acceptable preceptors sometimes. So this has led to the emergence of postgrad residencies and fellowships, including the first CL fellowship for nurse practitioners at University of Rochester. Here is a summary of the practice environment going from full independent practice to restricted practice to the in the middle option, which is reduced practice, which means that there's some restrictions on at least one practice element, and there needs to be a collaborative agreement, but these agreements really vary by state. This is found on the AANP webpage as well, but this is the National Council of State Legislatures, if you wanted to check out this, this page. For PAs, so typically there is more of a standardized curriculum than NPs. For example, some programs require patient care hours to apply for the program. PAs typically do a bachelor's, and then the program is 2 to 3 years for a master's degree to train as a generalist. And then there are additional requirements for psychiatry. It's called a PCAQ, or Psychiatry Certificate of Added Qualifications, which is typically 2,000 hours and requires attestation by a supervising physician. Exams are standardized with one governing body. However, clinical experiences can still be pretty variable. PA student preceptorship experiences may be lacking, and program directors in a big survey were concerned about graduates' preparedness for practice. Hence, PA fellowships and residencies have also sprouted up. Unlike NPs, PAs require physician supervision in all but 2 states. Here's a graph that summarizes patient care hours during the training of each respective profession. I also wanted to touch on the origins of APPs. So PAs were created in the mid-60s by a physician to improve and expand access to healthcare, as there was a PCP shortage. And this initially started with folks with a military background who had received some medical training during their military service. So it was aimed to kind of fast track entry into the medical profession and people who already had clinical experience. The AMA then recognized the PA profession in 1971. The NP profession was started by a nurse and a physician together to also address PCP shortages and also make use of nurses' existing clinical skills. And then federal funding led to the rapid spread in the 70s, including to specialty care. Originally, NPs could not prescribe, but this changed quickly per state laws. Also, though the profession was initially created to leverage bedside nursing experience, there are now some programs that allow direct RN to MSN programs without clinical nursing experience. Now that we have some basic details of the professions, we'll start talking about how do we relate to these professions as psychiatrists. Depending on what state you're in, you might be a collaborating physician or a supervisor. You might lead an interprofessional team, for example, as the medical director of a community mental health organization. In our opinion, psychiatrists are best equipped to lead teams based on our deeper clinical and leadership training, for example, learning to supervise via years of being a more senior learner. Team leadership skills, though, could be a whole nother talk. Personally, I have weekly discussions with an APP. I'm a physician collaborator at one of our community hospitals where we discuss cases and resources for further learning, and I sometimes chart review some of the cases that she's involved in. So you may be, colleagues working on a team or working in parallel as well. And then as a trainee, the relationship can be awkward and ambiguous. There's not really anything in the literature. So it's not great for either party to assume that they're the teacher or the learner, especially given different training backgrounds and experience levels of APPs. There are a lot of things that you'll know more, but as we discussed, APP's training background is often opaque, so we don't want to make assumptions. Also, experienced APPs may have more years under their belt, clinical years under their belt than fresh grad physicians. For example, especially being earlier career, I often ask our transplant psychiatry APPs who have years of experience about transplant-related things like tacrolimus toxicity. So theme that will come up in this talk is to just err on the side of asking about someone's knowledge and background before just launching into a teaching thing or launching into a clinical description where you're assuming that they've heard of XYZ niche thing before. So it would distract from our purpose to dive into comparisons of the quality of APP versus physician care, as there's a lot of controversy and mixed data. In summary, there's some data that outcomes are comparable, but some that NPs order more tests and referrals. This is mixed data though. Anecdotally, we do hear about some medication safety concerns for green APPs, especially fresh out of the program. There are also anecdotes of physician jobs being replaced with APP jobs. However, psychiatrists are still in high demand, as exemplified by the jobs page of the APA website, for example. Focusing on more descriptive comparisons. So APPs may see simpler cases, so we can leverage our expertise. Ideally, APPs may make our lives easier by improving continuity of care and providing additional psychoeducation. Experienced APPs may carry institutional knowledge that can help fresh staff or fellows help us navigate the system. Another truth is that supervising an APP, especially a fresh grad, can be complex and hard work. Regardless, APPs are here to stay. If you do find yourself in the position of applying for or doing a job that includes APP supervision, here are some tips that, based on, honestly inspired by Dr. Wilkes's APA presentation, but based on conversations and my own experience. So we want to negotiate for supervision time, even if you're not doing direct supervision, even if you're not in a state where it's a restricted practice state where you are the supervisor. You want to, make sure that you're negotiating for time, because chart reviewing, doing indirect supervision can take a good amount of time. We want to consider the need for this indirect versus indirect supervision. So titrate this based on the APP's experience level and also the complexity of the patient. And along those lines, we want to consider escalation protocols. So in certain complex clinical situations, when should the APP reach out to the physician, to you? When should they consider transferring care of the patient to you? We want to make our educational differences explicit. Again, like when in doubt, ask. And we want to know our state laws. So some resources for this include the National Conference of State Legislatures, and also nursing and medical board websites can include state laws. We also want to know our institution's policies and talk to our colleagues about their practices for supervising. And, we want to make sure that we are doing best by our patients and by APP supervisees, but also we want to make sure that we're aware of these things, because liability does not necessarily decrease if supervision is more indirect, or if your state is reduced practice, that middle ground rather than the restricted practice. So it's good to know these standards so that we are acting within the legal standard of care as well. Next, some non-APP professionals that we commonly encounter in CL. So psychologists, they may just have bachelor's and master's, but these folks typically go into HR or project management. We might not see them as much on CL. Doctorate level psychologists, who we do encounter more frequently on CL, may have a PhD or PsyD. The PsyD is usually more clinical and the PhD is usually more research focused, though there's definitely some overlap. So psychologists go through several years of doctorate training, plus a year of internship, plus optional fellowships, including in CL, which the CL psychology programs are in fledgling form. There's not too many of them. And then social work, so they can have very diverse training backgrounds and roles. They may have a bachelor's plus or minus a master's plus or minus extra supervision training or clinical training. Roles can include case management to therapist to diagnostic assessor. I've also made an appendix that includes information on other specialties. Another hot topic is prescribing psychologists. So prescribing is allowed in 7 states. It requires a doctorate in psychology plus a 2 to 3 year psychopharmacology master's. You have to pass a national test and then get a state issued prescribing certificate. They can prescribe psychotropics only. And then there are some state specific restrictions on controlled substances, how much supervision is required, whether it's just at the beginning or ongoing, whether they can see certain medically complex populations, and whether a PCP needs to be involved or how involved a PCP needs to be. Of note, prescribing psychologists are much slower spreading and much more limited in scope than APPs. And there are advocacy efforts by psychiatrists to push against this given safety concerns. Speaking of professions being at odds with each other, we'll discuss some barriers to collaboration next. There are some outspoken critics of APPs. I'll give you a moment to read some of these Reddit posts. I assume most of you are familiar, but Reddit is a popular national message board on all of the topics. I did want to admit I may have lurked on these pages in the past. I was aware of some of the patient safety concerns, and I think that reading some of this may have served a certain emotional function for me during a stressful time in my early career. Next posts are from pages for NPs who recognize the lack of standardization and the struggle. As I gained more experience clinically, felt more comfortable in my own shoes as a psychiatrist, gained experience working with APPs, and read and reflected, I started to recognize the risks of this battle that we have with APPs, but also with other professions sometimes. So hierarchy or attempts to wield authority may especially in the case that we talked about at the beginning, may worsen patient-related communication and lead to errors across specialties, which affects everybody, all providers, not just those who are embattled. Talk about the battle distracting from the tasks at hand. So this is a psychodynamic framework that helps us understand why we tend to battle. Similar to how our individual defenses try to protect us from distressing or intolerable feelings or situations, there are certain group defenses that also operate to protect us from a distressing reality. Groups vacillate between 2 mentalities or ways of functioning. There's the basic assumption processes, which are based in fantasy to protect us from reality. and work group processes, which are more task-oriented. So in terms of the basic assumption processes, we have fight or flight, which is self-explanatory. Per the case, it's the NP's suck comment blocking the consult versus do we get out of medicine? We're so distressed. Dependency/pairing is where a leader or a pair of members become seen as all-powerful. So the folks may pin their hopes on the leaders and disavow any negative feelings, withdraw from doing the work. So in our case, the fellow may be like, it's not my job to educate this hospitalist NP about what's a good consult. My program director can do that. This is like a systems level thing. So these basic assumption processes assuage anxiety, but distract from patient care, task at hand, whereas the work group processes are oriented toward patient care and discerning the truth. So an example of this would be figuring out what was actually going on with the patient in the case and how to help. The use of group defenses implies that we have intolerable anxieties. So what might these be? For APPs and other professions, our anxieties may center around role ambiguity or scope creep. So what do I do versus what's their role? Are they going to take over my role? Are they going to try to make me do work that's not in my scope? There's job insecurity, the risk that insurance will require a less trained clinician or only pay at that lower rate. There's sacrifices and the cost of training, which we are familiar with in the sense that other professionals can't fully appreciate our sacrifices. We may feel underappreciated. There may be different supervision requirements, especially as trainees, as fellows who have some years under their belts. Fellows may still have to report directly to an attending, while a less experienced NP, fresh grad, may be able to practice independently, depending on your state. There is trainee status in general. As trainees, we often feel unheard, disempowered to make changes, and our professional upbringing is pretty invalidating. So, like third-year rotations, we know how it feels like to feel like a nuisance, get a lot of criticism and not too much praise. And so I think that we have an unstable professional sense of self that is vulnerable to perceived and real threats. And this can honestly bleed into attendinghood as well. I definitely have experienced this in my day. And then finally, the original purpose of APPs was to address rural shortages of PCPs and leverage clinical experiences. But now there's the cities and programs that don't require bedside nursing experience. So this is, this incongruence can feel anxiety inducing. I tried to face my own anxieties head on by diving into being part of the solution. A few of the ideas here I've tried, and a few, we recommend just based on the literature and experiences. So recommend separating systems from individual issues. In other words, try to avoid scapegoating, as individual caregivers are generally trying to do the best they can. I don't think there's anything wrong with participating in systems level advocacy to push against scope creep that we think could be, harmful to patients. However, I'd recommend then compartmentalizing and refocusing on the patient in front of you. We can become aware of these group dynamics so we don't enact them. We can learn more about our non-physician colleagues' backgrounds and scopes to, one, increase empathy, and two, refocus on the work task by, maximizing each team member's ability to advance patient care via a logical division of work. We can teach our colleagues, so help the hospital's NP understand how to formulate a good consult question, discuss why a psychiatrist might be worried or less worried, and then they'll formulate a better question for us next time. As a leader, we can identify, contain, and process the anxieties. And full disclosure, that was part of my goal in diving into this in this talk. you can step into the leader role and help people process. And finally, learning collaboration strategies. Again, but why collaborate? This seems like a lot of work. Why should we put in this work? I talked about the risks of the battle, and now we'll touch on the benefits of effectively collaborating. So physicians are poised to lead and teach. If we don't lead across professions, others will step into that role. Also, again, we want to help them help us. A goal of this talk is learning folks' backgrounds so we can leverage their abilities to smooth the path for our tasks. So psychologists can spend more time on behavioral interventions while we do, briefer interventions focused on psychopharmacology or other things. APPs can provide care for the more stable patients, freeing up more time for more complex and interesting cases. Also, patients benefit from us collaborating effectively. How many times in CL have we heard about patients suffering from this team? I'm getting all these inconsistent messages. Nobody's talking to each other. And finally, because we share responsibility for reducing the cost of healthcare and improving access. So it's another reason we should collaborate effectively. So what has worked well in trying to work with APPs and other professions, and where can we improve? Take a moment to think. Finally, let's move on to practical pearls for working together. The first framework stems from interprofessional education, which has a burgeoning literature, and there are interprofessional education offices that are sprouting up within academic hospital systems based on this literature. It's defined as when multiple professions learn with, from, and about each other to improve collaboration and quality of care. That said, there's not a ton of IPE research in CL or even CL adjacent settings. However, our group did our best to synthesize concepts from the IPE literature that apply to CL work. So this slide came from the general IPE literature and are, practical. There are IPE initiatives and like formal teaching programs, but this is outside of the scope of this talk. So, how do we learn from IPE concepts though in CL? So we want to make scope and background explicitly invite new team members to communicate their view of their own scope, which can happen during rounds, formally or informally by asking questions like, do you think there's a role for you in this case? If you're creating didactics or a course, consider a formal needs assessment survey and getting multiple iterations of feedback. We want to clearly delineate tasks. We want to create a psychologically safe environment, but how do we do that? So we invite input from everyone of all professions. We want to solicit feedback of ourselves. We want to invite dissent. Like, does anybody disagree with what I just said? I really want to hear all opinions. Also reward the commitment, not the answer. Pick out what's good first. So if somebody is proposing something and you're noticing, maybe a hole in the logic, focusing on what was accurate first, praising that, and then focusing, teaching on course correction for the logic. We also want to hold live conversations as much as possible. We want to get over that social anxiety and talk rather than, lay out all of our thoughts in an epic chat, which is less anxiety inducing, but kind of disallows the reciprocal communication that's needed to get the whole picture. And then we want to model positive regard for other professions, and finally set aside time for reflection on processes, on the group process included. So what worked well with this meeting? What surprised you about other professions? What's working well with our teamwork generally? Or if you're the leader asking for feedback on how do you feel like I did in facilitating this group? I'm, really interested in constructive feedback. Next, liaison approaches can shed light on how to best collaborate with other professions. However, liaison has not been well operationalized or studied. So bolstering this literature is something that myself and my colleagues are working on. Any competencies on this are vague. They mention communication and teamwork skills are needed, but how and which skills? The ACLP website does have some helpful how-to guides that highlight liaison relevant skills such as creating behavioral care plans. And there is some literature, mostly old from the 70s, on the foundations of CL and applying dynamic approaches such as the liaison stance, which I'll dive into in a moment. And there's some other recent papers on specific liaison relevant skills like negotiating, also identifying the implicit question, especially for capacity consults, and cultural humility. Here's a tentative list of the skills. Think about what else you might add. The liaison stance, I wanted to provide a sampling of skills and from the liaison literature, and the liaison stance is one of those. I encourage you to pick one to try to apply in the next month. So the first skill is adopting the liaison stance. So this positions the CL psychiatrist as a participant observer per psychodynamic literature and balances being engaged in the clinical situation with observing the dynamics of a situation. It posits that the CL psychiatrist can influence staff behavior while considering ethics. Obviously, we don't want to quote unquote manipulate staff unless we have patient care as the goal. An example from one of these old papers on the liaison stance is this patient with, cluster B borderline traits who's escalating, yelling at staff, threatening liability if their requests are not followed. Not familiar to anybody, right? So the CL psychiatrist can help by expressing frustration, even subtly, like a little eye roll, which encourages others to vent and can also validate others using the global we. So saying something like, wanting to punch the patient in the face makes us feel guilty and out of control. We may use suggestion to prevent the primary team from enacting their wish to punish the patient. So saying something like, some doctors will want to force the patient into psych treatment or discharge without treatment. This patient requires a lot of tolerance, more tolerance than most providers, most physicians have. I would say a little bit of a gray area in terms of manipulation. I would, love to hear from folks their thoughts on this. And then finally, psychoeducate. So we can explain chronic personality traits and how the patient may divide and aggravate staff. I think it's also important to touch on like how some of these personality traits develop to build empathy. So a lot of them come from a trauma background. So framing it in that way, I think, is a way to improve empathy. Another liaison skill that can apply to interprofessional collaboration is negotiation, in which the CL psychiatrist can problem solve and mediate conflict to try to move care forward. Capacity questions are often an indication of conflict between the team and the patient, so they're ripe for negotiation skills usually. Yeah, I want to encourage people to go in the references and actually read this paper. I don't think I can do it justice in briefly describing it, but in summary, we want to separate people from the problem or prioritize relationships. We want to identify underlying values and interests rather than precise positions. We want to use objective criteria like medical data, and we want to create options that address underlying interests or values of multiple parties while preserving relationships. Given the lack of literature with unifying liaison frameworks and the lack of literature explaining the application of interprofessional education to CL, another approach to learning to collaborate is to just talk straight to the source. I solicited input from several interprofessional colleagues asking the question, how can psychiatry trainees and psychiatrists best work with you? What are some common misconceptions? So I want to go through what I found out. So with nurses, folks with nursing experience pass along to me that even if a nurse doesn't know what's wrong or how to describe it in precise language, they often know that something is wrong through the eyes and ears and may have a sense of when CL can be helpful. Nurse practitioners shared, we want to learn. They're aware of the tensions and they say complain in private, but then turn complaining into teaching action. So we're all part of the team, have diverse perspectives based on diverse training models and clinical experiences. So be mindful of experience level, language, consider, this is the NP on my team versus this is my NP, how that feels. If your address is Dr. Smith, you could consider like NP Smith or PA Smith, but should ask, again, the theme being ask people's preferences. As a future systems leader, you can have physicians and NPs share patients, so less siloed work. In addition, some physicians who work closely with APPs found benefit in focusing on real-world case-based learning as much as possible and to flesh out clinical reasoning, as anecdotally, they found that some of their APP supervisees tended to rely on algorithms. PAs. So first and foremost, PAs wanted to relay, support your PA, present a unified front. Some patients may ask to speak to the attending, and I think that can be considered. But as the attending, when you're coming to talk to the patient, like making sure that the patient is aware that the PA is, an extension of the team, is the boots on the ground, and can be the continuity person, especially if the attending is pulled in a different direction. And most of the rest of this PA advice is based on the supervision model and the physician as an educator, which is, more clear-cut arguably than the NP-related advice. So in summary, titrate supervision based on experience, moving from direct feedback and learning resources to guiding decision-making to building advanced decision-making and leadership skills, to allowing PAs opportunities to create policies, protocols, be involved in the systems level workings. The biggest theme from social work was to recognize the diversity of social work roles. So some social workers have the case management role, driving people around, helping them with their basic needs. Some social workers have clinical licensure and don't do dispo planning. Social workers in the community may take on more roles, wear more hats than a well-resourced academic institution social worker. They said involve us early, which ensures that dispo planning is realistic and that there's enough time to get the referrals in place, and also helps identify barriers. So insurance issues, transportation, mobility issues, which may preclude like placement in a substance use rehab. Also, if the patient's pre-contemplative, good to know early. You may know what the patient needs at discharge, but sometimes the thing that the patient needs is not non-existent, or there are barriers, and the social worker can sometimes be the brunt of some displaced anger about what is not possible. Said sometimes something is better than nothing, and we have to accept that. Radical acceptance. The social worker is the bridge, not the barrier, and can work to navigate these barriers. So if they say, please don't shoot the messenger. So also sometimes teams will say, I want social work to make the follow-up, but a lot of times the social worker is not the best equipped for this. So for example, some of the substance use disorder places will want the patient to call themselves to show that they have motivation, or because the patient has the information required to, to carry out the referral. And then procuring housing is often not a realistic goal if hospital admission is another message that they wanted to make sure that we were aware of. Psychologists said that they wanted to break down silos. They want us to coordinate regularly with outpatient therapists. They, said that this can help with delving deeper into certain issues for both the therapist and the psychiatrist, and can help brainstorm about some of the diagnostically complex cases. They would love to tag team complex cases to, reduce frustration. And when you're making requests of psychology, they requested that we describe what we're seeing. So persistent negativistic thinking around body image, and clarify how you're wanting to collaborate, whether that's co-treating, transferring care, or group siding. They said we should try to leverage specific expertise, including use of psychological scales, creating behavioral plans, psychotherapeutic interventions, including CBT for specific symptoms like pain and insomnia. Pharmacy said that a bigger problem than friction or unrealistic expectations is not knowing pharmacists' skill set and not reaching out. So they suggested to have an open door policy, reciprocal communication, and try to integrate pharmacists into rounds or co-locate if you're a leader. Pharmacists can be especially helpful with transitions of care, medication reconciliation, complex med regimens with potential for interactions, education, and developing individualized plans. OT also said the biggest issue was lack of knowledge about what OT does, which is to focus on acute injury rather than chronic injury or dysfunction. You can always ask OT whether the order is appropriate. OT can help with discharge planning. I talked with nutrition as well, who spoke of, again, knowing their scope, which is assessing malnutrition, doing physical exams that are targeted, assessing the need for enteral nutrition, providing, evidence-based nutrition therapies and education. They commonly work with CL psychiatrists in GI site comorbidities and eating disorders. They wanted to relay that their main role in the acute setting is the medical stabilization of eating disorders rather than long-term meal planning. They said that things that we can do to collaborate with them include reinforcing the recommendations with the patient and addressing any potential mental health barriers to these recommendations, such as trauma responses when food is reintroduced, and just having those reciprocal conversations again about how do we, meet all of the goals of the multiple teams. Primary teams. When I say n equals a few, it means I reached out to some folks and then they reached out to some folks, and so we have multiple people's input for these recent slides. They wanted us to understand the core question, provide clear, timely, and practical recommendations, discuss things live if the situation is complicated or if treatment's not working. So they want us to take ownership. So especially when waiting for inpatient psych, they want to see their patients start to get better. So they want us to start, the antipsychotic or whatever med that might be started on inpatient psych. They are invested in how their patient is doing from a mental health standpoint. They want us to explain our rationale. So if we're saying it's not psych, provide explanation and any potential recommendations for other directions to go. And they specifically said they wanted us to comment on whether capacity is restorable. I think it's always good practice to comment on, why the patient lacks capacity and then the restorability, which can then guide the medical management. And finally, neurology. So this is a combination of a neurologist's input and literature that's specific to neurology. Previously, neurology and psych were integrated into the same specialty, but recently became more siloed. And additionally, neurology is increasingly being siloed by subspecialty. Psychiatrists can focus more on structure of the CNS and do focus neuro exams, and neurologists can benefit from honing their mental status exam and do sensitive interview skills. So less siloing, more mixing of our skill sets so that we're, on the same page working from, similar sets of data. We can communicate live and use shared language. We can be organized, concise, and specific in our recommendations and make contingency plans. So even if the patient isn't currently agitated, if there's a risk of that, giving recommendations for if the patient becomes agitated. When consulting each other, introduce each service's role to the patient. I think we're all familiar with when the patient is not told that psychiatry is consulted. So similarly, if we're asking that neurology see the patient, they said, just prime the patient about what might be done. Neurology, they may do like a focused neuro exam and provide some recommendations. And the question to be answered, like why you're wanting neurology to be involved. They said focus teaching on when the patient may need inpatient psych care or psych med adjustment, especially for outpatient neurologists who may be less familiar with the reasons for psych referral or inpatient psych care. So some overarching themes with all of these empiric conversations include being humble and curious about your colleague's background, their experience level, their scope, ask if unsure, involve other services early, and live reciprocal communication is best. It helps us develop shared goals. Alrighty, thank you for your attention. I hope that this has helped you start to think about how to work together with our colleagues so that we can best serve our medically ill patients. There is still so much to learn, and I'm open to any ideas and feedback, so feel free to reach out to me by email. Here are the references. And then we have a little bit of an appendix that folks can check out on the PDF that will be posted. Okay. Goodbye, everybody.